I'm going to start with a statistics. You probably know this already. Cancer is a leading cause of death across many populations, and that is worldwide. But did you know? I didn't know this. It accounted for nearly 10 million deaths in the year 2020. That's nearly 1 in 6 deaths. Cancer care, that's also a contributing factor to these numbers. So this panel is going to explore cancer care and the challenges that people face when it comes to quality care, prevention, as well as treatment. Our moderator for this panel is Amy Cho. Amy is an award-winning general assignment reporter and fill-in anchor for News 4 here in Washington, covering everything from health to education, government and politics, and breaking news. She won a Regional Murrow Award for her work on a 30-minute Stop Asian Hate special. And on a deeply personal note, Amy is a cancer survivor, bringing firsthand insight into today's conversation. Please welcome Amy and the panelists to the stage.
All right. How's everyone doing? Good, I'm glad. My name is Amy Cho. Like she said, I am a general assignment reporter and fill-in anchor at News 4, and I'm so excited and thankful to be here with all of you today. 3 years ago, I was diagnosed with stage 2 Hodgkin's lymphoma. It was such a shock. I was 27 at the time, never, ever, ever imagined it. It flipped my entire life upside down, and I was so stressed and scared, but with the help of amazing doctors and nurses and family and friends and my station, I was able to finish chemotherapy, and this Thanksgiving, I'll be celebrating it 3 years cancer-free. And I think it's probably safe to say every single person in this room knows someone who has been affected by cancer. And so I'm so glad that we're all coming together to talk about this terrible disease, but also the hope on the horizon and the incredible work that my panelists here have been doing in this space. So I'll let each of you introduce yourselves and just briefly talk about the work that you do and why you got into it and why you're passionate about it.
Good morning, y'all. I am Dr. Aditi Bustles. I am playing 2 hats today. I'm an epidemiologist by trade, but I also have the honor of serving as the at-large councilwoman in Columbia, South Carolina. My city is about 1 million people in the greater area, and a unique kind of feature for me is that I actually represent a majority Black city. And I'm in a very unique role. As you all can probably anticipate, the American South is not as much represented by our Asian American communities as I would like. So please come move down there. But we do have some really, really great things going on. And I'm very excited to talk about how public health can very much intersect with local policy.
Good morning. I'm Gary Puckrin. I'm president of the National Minority Quality Forum. What really drives me, and first of all, glad to be here. Such a great conversation. The early panel was just fabulous. What drives me is we are in the middle of a medical revolution. When Nixon started the war on cancer during his administration, we did not have the science and technology that we have today. We can literally bring cancer under control over the next 25 years. And we're not doing it. I think the message that I would put out is we can actually do really great things together. And one of the places that we can learn that is really with cancer. The science and the technology. When you look at cancer right now, we have the ability to detect changes in blood chemistry 2 years before we even get to stage 1 cancer. But we're not deploying that technology. So that's my message. That's what drives me every day, is that we actually have the capacity to do something that is absolutely incredible.
I totally second that. Hi, good morning. My name is Yang Hee-woo. I'm a surgeon, but I'm a 1.5 generation Korean American female robotic surgeon scientist. So it took me a really long time to get here, but the 1.5 generation Korean American part is very important to me. That drove some of the things that I do and selections that I have made in my career. So I focus on the treatment of stomach cancer. And how many of you know anything about stomach cancer? Good. Did you know that all of you are at increased risk of developing stomach cancer and 2 to 13 times risk of dying from stomach cancer in the United States as you are Asian American and if you are African American and Hispanic American? And how many young Hispanic men are sitting in the audience? None, but there you go. So you're the only population in California that has an increased incidence of stomach cancer, representing United States. So this is the cancers affect us all differently. And talking about science and technology, the goal for me is to bring the best of technology and science to cure a cancer that disproportionately affects ethnic minorities in the United States. But globally, it is the number 5 cancer and the 4th leading cancer killer. But in the United States, it's 15. And if you just look at general population statistics, it doesn't reach that high. But if you look at it specifically in specific subpopulations, it affects us differently. So the goal is to eliminate deaths due to stomach cancer in my lifetime, as you said, that we could, hopefully focusing on personalized medicine that takes into account ethnicity as well.
Good morning. Real pleasure being here. Juliet Choi, President and CEO of the Asian and Pacific Islander American Health Forum. This is personal and it's also core to our mission at the Health Forum. We're a national health justice advocacy organization. We have a presence here in Washington, D.C., where we try to dialogue with the executive branch and the legislative branch. Our priorities, the sense of urgency of our work is driven by our community network that has grown to almost 300 with a reach into 44 states. So I would be curious where everybody is from. And I'm hopeful. I already see in the room, we've got some partners of the Health Forum in the room. You know, a couple of things I want to share and why this work is so important. You know, outreach and education. I know we say that a lot, but it's so critical. It is so critical. So one of the trends that I want to share, my personal exposure, thank goodness I had wonderful treatment, got my annual mammogram about 7 years ago. I had a breast cancer scare. Thank goodness it was benign. But it's because I know to go get my annual mammogram. A new trend since 2000 for Asian American Pacific Islander women under 50, there's a 50% increase in breast cancer. Not 5%, but 50%. And I'm looking around the room and I see a lot of young people. I see probably moms and aunties. How many of us know about this trend? And then the flip side of that, in terms of why advocacy is so important, why it's so important to mobilize our voices in Washington, D.C., is that the number one agency in the United States that does research, that leads cancer research, is the National Institutes of Health. I won't discuss the plight of federal government today. That's another discussion. In 1992, the multiple billions of dollars that NIH has, 0.12% was allocated to AA and HPI research. Not cancer research, research. Has that number increased? The last time folks took a look at it in 2019, less than 1% of about a $45 billion budget was allocated to research for our communities. So for those of you in your local community, you're here in Washington, D.C., our corporate partners and our foundations help us lift our voices. Gary's talking about a medical revolution. I wholeheartedly agree. The flip side of it is we need to ensure our communities are not visible and that we're not left behind.
Absolutely. Thank you all. Looking forward to hearing more from you. Dr. Bustles, I'll start with you. You have such a unique background with the intersection of epidemiology and also government. So talk, if you would, about what role cities can play and governments can play as far as cancer prevention and cancer care, and what people need to know.
So the first thing I would say is that cities are the incubator for innovation. When you think about a lot of the innovative policies and practices that kind of bubble up to the federal level, a lot of times they're started from a pilot perspective in cities. So if there is a community-based program or an approach that we want to adopt, I'm always open to finding ways in which we can partner with the experts in the room or in the field to then use our platform as the capital city of South Carolina to see if that can actually make an impact, and then go and advocate to our state and federal legislators to make it even bigger and better. So that's the first thing, is that we are certainly the incubators for innovation, and that especially in a time where I think a lot of federal cuts have very much impacted. So we are home to the University of South Carolina, which is an R01 institution. It has impacted a lot of our research that's happening, but that's really where cities and health systems and other non-governmental partners can really step in and continue that innovation, look at creative ways to continue to conduct research, prevention, and treatment. For me, I think the biggest cross section is I believe that cities have the ability to create environments that can prevent cancer from happening in the first place. So when I think about that from an environmental perspective, quite literally, but then more broadly from a sociopolitical environment as well. In terms of environment, one thing that's been top of mind for so many cities has been the growing awareness and potential harm of PFAS. And there have been a lot of regulations that have come down from the Biden administration that was to regulate the water quality. What does that look like, practically speaking, for us to be able to do that? What does it mean in terms of potential health outcomes and risks associated with cancer because of PFAS? But then also, what does that mean for our customers where we provide water and the cost that's associated with that? So we've been thinking about things like that a lot. Of course, those regulations might change in the current administration, right? So what does that mean in terms of the knowledge and the potential fear and distrust of this is already out there? What can we do to mitigate some of those concerns, but then also find creative ways to address the very real threat of PFAS? And then in terms of environment, I'm a child health researcher. I strongly believe that prevention starts as early as possible. And when you look at a lot of public health campaigns that cities have done or local governments have done, oftentimes we unknowingly and unwillingly we'll just focus on the individual behavior. We'll say, like, that smoking is wrong for you. Why are you doing it? There's all this research out there. You shouldn't smoke in front of your child. That we forget to ask what led to engaging in that behavior in the first place. And when you look at immigrant communities or communities of color, there's no surprise that there's a lot of stress, both in terms of systematically, but also through their journeys of immigrating into this country, or, the historical segregation or discrimination that has led to some of the issues that we're seeing today. And so that's where I think that cities can also then start early in life to create environments for children, for their families, so that they're not in an unsafe neighborhood where they're exposed to violence or exposed to environmental toxins or exposed to things that could, potentially increase tenfold their risk of all of these cancers later in adulthood.
And we're also seeing that with all the warnings now coming out about alcohol and the risks of drinking as far as cancer. But I'm glad you mentioned, we're not asking necessarily why that's an issue. So Thank you for bringing that up. All right, Dr. Puckern, I want to come to you. I was very touched and struck by what you said about the possibility that, we can have cancer under control, but it's not happening. And these technologies are not being deployed. Why is that? And what do you think needs to be done?
So, the fact of the matter is our legacy healthcare system, that's the way we describe it at NMQF, is a rationing healthcare system. It's a tiered system that was developed in a period in American history where inequalities were accepted. And so what we've been thinking about is, so how do we bring all of this science and technology into community? I'm going to give you a specific example. We're doing work in Houston, Texas, in the 5th Ward of Houston, Texas. It has a documented cancer cluster. And so what we decided to do was to use some of this new science and technology to surveil the population for cancer. Working with MD Anderson and Quest Diagnostic, we are drawing blood from the population in the community. And what we're able to do is risk assess them for the prevalence and type of cancer. So rather than be passive, screening technology in the past has been passive. Yes, you went to get your mammogram, but you had to decide to do it. Lung cancer, we've got the technology not being used. So what we do, we literally go knock on doors and we say to people, we need to get you screened because you have an elevated risk for cancer, because you have been exposed to environmental toxins, and we want to be proactive. And that's the word I'm telling you about this medical revolution, is that we have to now be proactive and we have to find the money to do it, right? You hear a lot of conversations in this Congress, in this America right now, that we should be cutting the healthcare. Nonsense. We have to invest in healthcare. We have to speed it up, because guess what? We don't want the next generation to have to deal with what we're dealing with, particularly when we have the power to do it. And so we've been enrolling people into a study. We're about to go into Flint, Michigan, the water crisis in Flint. So we're finding those hot spots around the country to go in and bring all of this new science and technology. I've been talking to you about screenings, but we could talk about immune therapies that don't get to these populations, et cetera. So here's what I really say to you, and here's where you need to use your voice. We have the capability to do what we did with HIV to cancer. We can do that any day we decide collectively to go do that, and we're not doing it. And so we want to raise the flag and say, we need to end this war on cancer. We have the science and technology to write that final chapter, and we should go about doing it. And the final thing I want to say, because I always like to spill a few numbers, and these numbers I think are really important. There are 40,000 zip codes in the United States where people live. 70% of African Americans live in 2,500 zip codes. 70% of Hispanics live in 2,500 zip codes. 50% of Asians live in 2,500 zip codes. So when you add it all up, what we're really talking about is 8,000 zip codes around the United States where we see this excessive risk for cancer. And what we're saying is we need to invest in those communities. We have the capacity to bring this thing to an end, and we need to do it now.
Dr. Cochran, thank you. Dr. Wu, I want to come to you next. You spoke about how it is a fact that Asian Americans are more likely to die or to have certain types of cancer. Talk more about the work you've done with clinical trials and research, why you've been such a passionate advocate for diversity in this research, and how the landscape is looking these days.
Sure. I think we all know that a lot of ethnic minorities do not enroll in clinical trials for various different reasons. Availability, understanding of it, concerns about enrolling in the trial and what it means, what clinical trial means. We had a meeting with NCAACP when we had our early detection prevention trial for stomach cancer. And one of the things I didn't realize is that even though the trials are open, the community may not want to participate in the fear of what it really means to them. So most of you may not know the recent clinical trial. So all of this technology and science that needs to come to you as a treatment, like your blood pressure medicine, your cancer drugs, even the use of robotic surgery, has to go through clinical trials. So phase 1 clinical trial, does anyone know what it tests? It tests for toxicity. It tests for dose that's acceptable. So from the first phases on, when a new drug is developed into getting into you as a treatment, phase 2 tests for efficacy. Okay, and I'm going to bring this all back, why it's so important for you to participate in our community. Phase 3 is a randomized. They compare the standard of care best practice to a new intervention, new drug that comes out to be added to see what is superior. Well, if you have a phase 3 trial that shows efficacy, then it becomes FDA approved after review, and insurance companies, I saw some insurance companies here, they have to approve it and pay for it if you're insured, and Medicare and Medicaid. There is a thing called ethnopharmacology. I'm a surgeon, so I had to read up on all this. So I'm just sharing this with you and why this is so important. Different drugs affect us differently. the toxicities of certain drugs that are available, for example, S1 that's available in Korea, Japan, and China for the treatment of stomach cancer, which is very effective, is not available in the United States. Do you know why? It's because when they did the trial with S1, the GI toxicity was too high in the trial that was run, phase 1. Never made it to phase 2, right? But who was in the trial? Probably not that many Asians or Hispanics or Blacks at the time. So what I'm saying is, in order for the drugs that come to us, FDA approval for insurances to cover, and the dosage and efficacy that reflects us as a community, we need to participate in those trials. And some of the barriers is that when you design the trials, it can't be that after the design of the trial is made that you go and you try to recruit patients. Because of the 40 somewhat patients that are Asian American that come to see me for stomach cancer, more than 50% do not speak English as the first language. So what does that mean? Well, when you design the study, the informed consent has to be in multiple different languages, even non-Asian languages like Hispanic, as well as Armenian and Russian and Farsi, that disproportionately affect this population for stomach cancer specifically when we have studies. And so what else does it mean? Well, we need more resources to make the materials that go into clinical trials. So I can tell you about the clinical trial so you understand my clinical trial, but that takes more money, it takes more time. And talking about the number, decrease funding, stomach cancer NIH is 0.6% of the funding, and it gets lower each year. So if you cut it, then you almost cut out everything. So this is why it's so important to educate our community about the importance of clinical trials, because clinical trials will get you the drugs that treat us and cure us better.
Thank you, Dr. Wu. And Juliet, I want to come to you next. I was so glad you brought up the screening and the early detection, and so glad that you're doing okay. And if you could talk more about the importance of that and why you think it is that we see such low screening and early detection rates in certain communities. And speaking from personal experience, I do unfortunately know some people who have been hesitant to get things checked out and they said their mentality is, if I don't go in and I can't have cancer, because if I don't get told about it, I'm like, that's not how that works. You should probably go in. I'm no doctor, but so yeah, if you could talk about what you think can be done to combat that fear of the big C word.
Yeah, no, thank you for that. I'm going to throw out just a few more numbers before I directly respond to your question. So this is Asian American, Native Hawaiian, Pacific Islanders combined, the top 5 cancers. I'm just going to do it by gender. So for men, it's prostate, lung, colorectal, liver, stomach. For women, breast, thyroid, colorectal, lung, excuse me, and uterine. So to your point, when you go in and have your annual, if you're fortunate enough to have health insurance, I think there are some real critical systemic barriers. There's some research that backs this up, and it goes to your question as to why aren't we getting screenings? It's not just on us. It is that outreach and education, but there are systemic barriers as well. We've talked about language. We've talked about, I think we can't help but think about immigration status. If we come from a mixed status family or an individual's undocumented, there's going to be a chilling effect in terms of seeking care. One of the most obvious is, do you or don't you have access to insurance? And I know for a lot of us, a big priority is defending against the Medicaid cuts. But there's geographic isolation, there are cultural beliefs. And if I can take just a moment, this is where the community partners, the elected officials, especially locally, faith-based leaders, teachers, elders, the younger generation, Each of you have a unique opportunity and position to facilitate what I call these kitchen table conversations. Just asking the question, are we getting our cancer screenings? Let's start there. And then have that conversation with your care provider. For Asian Americans and South Asians, especially for older immigrants, language, but it's not just language, it's literacy. Insurance issues, coverage, for example, the uninsured rate for Koreans and Vietnamese and certain Southeast Asian populations, Native Hawaiian Pacific Islanders, the uninsured rate is extremely high. And inadequate provider engagement. Some of the cultural barriers for Asian Americans, I will say, a little bit riffing off of your commentary, there really is a stigma and a sense of fatalism for a lot of the East Asian communities. It's if I don't talk about it, if I don't go to my doctor, then it's not going to exist. But there's this notion also that if you do have cancer, it's somehow bringing shame to your family. It must be bad karma. It must be something that one did in their past life. For Native Hawaiians, one of the things that I do want to highlight is geographic isolation, especially the islands. I mean, do we have access to physicians that look like us, that can speak our language? And also, I'd be remiss if I didn't mention the absolute distrust and the health trauma because of colonization of the Native Hawaiian, the Hawaiian Kingdom. And also for Native Hawaiians, and I keep learning about this and try to read as much as I can. Families play a strong role when it comes to healthcare decision making, especially in Native Hawaiian families. And if there's a sense of creating conflict, it can delay seeking treatment and care. For Pacific Islanders, number one, Gary does such a great job of this. There's no data, right? Pacific Islanders sometimes, if there is any data, gets wrapped up into this broader category of Native Hawaiians and Pacific Islanders. But all too often, there just aren't enough numbers that it gets wrapped up under Asian American. And in some places, even Asian Americans, we end up falling in the category of other. So really the lack of data. Poverty plays a role, and especially for the Pacific Islander community, while the uninsured rates for the COFA population is very high, and Medicaid has been restored. That's only in the last 5 years. And so the outreach and education for insurance access is extremely, presents a barrier. And then the last thing for Pacific Islanders, again, just to highlight some of the cultural values, norms here that I think all of us can relate to, even outside of the Asian American, Native Hawaiian, Pacific Islander communities. Is a reliance or wanting to turn to healing practices first, not Western medicine. And so seeking traditional healers, and also that stigma of not wanting to be a burden to your family or even your faith-based community. So those are some of the systemic barriers, but also the cultural values attached to that. Again, I'll just underscore this is why our community health workers and trusted messengers are so incredibly key. The last thing I'll say is when it comes to gastric cancers, because it's not in the top 10 for the broader American population, it's not an automatic screening for our people. So screening is something very easy. And collectively, we need to find where we can mobilize our voices because treatment and the medical evolution, it's there for us. It's just that our communities are facing so many systemic barriers.
Yeah, I think meeting people where they're at is definitely something that cannot be emphasized enough. So, Juliet, thank you. And we actually are almost out of time. This has flown by, but I'll just throw this out to anybody who wants to take it. But if you have any personal connections, family, friends to cancer that you'd want to share.
Yeah, so I grew up in a family that always valued talking about our health. And, when your parents work as you're a kid, you don't actually think of them as anything more than your parents. But I went to go see my dad, and I think I was probably 12. And he spoke to a group of freshly minted, I think, doctors. And he talked about how he patented a biomarker for breast cancer on the behalf of the National Institutes of Health. My jaw was like, Papa? And when he when he got off that stage, I was like, "You never told me." And he's like, "Yeah, because I'm just Papa at home." And so to just have some of those experiences has really driven my passion to always integrate public health into the work that I do. I'm deviating it a little bit, but as I'm hearing some of the themes here, one thing I want to leave with you all as you all go out into your communities and do work around public health, don't get so caught up on the words and how we're talking about it. In a time that we need disaggregated data, we need to talk about the systemic or environmental issues. You don't need to call it social determinants of health or systemic racism to get the outcome, right? We're at a time where we just need to meet people where they are and make sure that the outcome we are seeking is the goal. And so I ask you all, use research as a mechanism, use data or this conversation around health as a way for you to meet in the middle as it comes to having some of these hard conversations around policies and programs, and worry less about the language. If anything, language can kind of sometimes keep us from actually getting to the end goal, which is more funding or more awareness or more training or whatever it may be. Ultimately, our goal is to be able to prevent the differing experiences that are leading to the differing outcomes. Notice how I said that leads to the disproportionate number of people of color and Asian Americans as it relates to cancer. And that's what you all need to focus on and find ways to talk about it that makes the most sense for your community.
I would just leave this message for you. We have the capacity to bring cancer under control, period. You need to elect officials who want to do that for you, period. There is no excuse of what's going on right now and the conversations that are being held that are destroying our intellectual infrastructure, that is taking away access to medications, that is creating the sense that they're providing value to you when they are in fact putting your lives at risk. We have the capacity to do this in every community in the country. And if we come together collectively, we can get that done. So I would say the war on cancer, we should be writing that final chapter every day, because by the time we get to 2050, we want to make sure that we have this doggone thing under control.
Quick closing thoughts, Dr.
Sure. I think we should continue to do what we're doing to solve the problems together, as this is a really uncertain time, especially for cancer surgeons, doctors, medical oncologists, and researchers in this field. I came with the ask that we would continue to work together to focus, maybe not talk about diversity, equity, and inclusion, and we have to take it out of our grants proposals because they've been taken away if you have those words. But in this uncertain time, find a new solution. I think by working together and doing what you're doing right now, the fact that we're all here to talk about it, I think is really important. Then I would ask that we continue with our collaboration. Thank you.
And Juliet, if you want to close us out.
Sure. I'm hopeful we will all meet again next year. The one question I didn't ask in the audience is, how many of you have had a cancer screening of some sort? So, very good, very good. Almost a lot of hands. So when we do meet next year, I hope all hands go up. I'll also want to ask the question, how many of you have facilitated conversations about cancer screenings with your loved ones? So we want more hands next year. Thank you.
Thank you all. Let's give a huge hand to our panelists.